Welcome to the Pharmacy Frontiers podcast, a podcast dedicated to the pharmacy profession. Daniel Good and Tim Mitchell are your co-hosts today, and we're excited to bring you the latest from the frontiers of pharmacy practice. Let me remind our listeners that the Pharmacy Frontiers podcast is available for streaming on your favorite podcast streaming app, whether it be Apple, Podbean, Spotify, or YouTube. Be sure to bookmark and like our podcast to get notifications on the latest release. The comments and opinions shared today are those of our hosts, our guests, and not official statements of the Missouri Pharmacy Association, Mercy, nor Mitchell Pharmacy. Now let's introduce our guest. Tim and I are excited to welcome back to the Pharmacy Frontiers podcast, Tripp Logan, the owner and operator for CMO RX Pharmacies and a CPSN Health Equities luminary. Welcome, Tripp.
Hey guys, appreciate you having me again.
Well, thanks for taking time out to join us. And this time we want to talk about the Rural Health Transformation Project that we know that you've been knee-deep in. Can you just give us a little rundown as to what does that really mean, health transformation?
Yeah, so definitely I would even say maybe like hip deep in it instead of knee deep. Just for those that aren't aware of Rural Health Transformation, where it came from, big, beautiful bill. Despite your politics, this is just, what happened. Big, beautiful bill, cut money out of Medicaid, offset some of that money with an investment in rural health. I'm not an accountant. My ledger doesn't balance with the amount cut versus the amount reinvested, but we'll move past that point and look at and say that $50 billion across the United States is being reinvested in rural health care infrastructure. Some of that money, and it's over 5 years. This is the first year, January 1 of 26 is when this started moving forward. It was a really fast-paced thing from last year through the third and fourth quarters of the year with proposals and so on. And I was lucky enough to work with some other colleagues at the Missouri Pharmacy Association to help with Missouri's application, which was like a Shark Tank thing over and over and over, which we could unpack later if we wanted to. And then in January, in late December, the award amounts for each state were announced, and Missouri got a significant amount of money. The awards were, some of it was guaranteed, like every state is an equitable amount. And then a certain percentage of the funds went to states based on how much rural area and how rural they were. And then the other percentage, another percentage was based on the application itself and how innovative it was. And there's some common tenets in the rural health rural health transformation proposals, and a lot of it was about interoperability, making sure that every healthcare provider in a rural area is not working in a silo; they're all working in the same direction, and that the sustainability of the healthcare infrastructure in rural areas maintains and improves versus just continues to get beaten down, like those of us that have practiced in rural areas for over 20 years have seen happen. So that's where we are. Missouri's in a cool spot. I'll say this multiple times, and I'll start right now. Without the Missouri Pharmacy Association's leadership, I do not think that pharmacists like myself in Missouri would be this involved in it. So I want to thank Ron and Annie and Robin and everybody, Carson at the association and the board for approving the work to move forward. It's been, hopefully it's going to be not only one of these short-term wins where pharmacy is at the table and involved in rural health transformation in the state of Missouri, but we have a seat at the table to help evolve healthcare in rural and urban areas in the state of Missouri moving past these 5 years. And so I'm really excited. I'm up on it. And again, thank you, MPA, for being leaders in this space, national leaders, not just in the state.
Absolutely. Yeah. So when this kind of money gets dropped down from the federal government to the states, I know the blood becomes in the water and the sharks start. You mentioned Shark Tank, and I'm thinking, yeah, the sharks start circling. And so I'm sure everybody is coming out of the woodwork wanting some of this money. How can we I know you just said the MPA is, and I totally agree, has been at the forefront, but how can we continue to push the profession of pharmacy into showing, you tell the story every day about how we have community health workers and how many of our many of our pharmacies are in towns that don't even have healthcare providers. And that's the first line. How do we preach that message more so the people that are deciding to pass out the money are giving it to the right places in appropriate amounts. So,
yeah, that's a really good. So when as we all know, we live in America. When $50 billion of government funds is going to be rapidly pushed to states, the like Tim said, the blood's in the water and the sharks start swimming immediately. And the more details, the more contacts, and the more political things get. And so as for those of us, there's a small group of us that are working on the Missouri Rural Health Transformation Project. There's MPAs working really closely with the state, DSS Medicaid programs overseeing it in Missouri. And then there are other associations, the Hospital Association, Primary Care Association, Behavioral Health Council. There's several other groups, DHSS and others that are involved, representing their downstream groups. And as we've been saying in our smaller group, and then CPS in Missouri, the MPA group, there's some others that are like one step removed. There's like 4 or 5 of us that are working directly. Then we have an advisory group, a little broad, and so on, all the way down to the MPA membership. But like what we've been saying internally over and over is you have to play offense and defense at the same time.
oh,
So
I'm sure.
you have to play offense in that oftentimes, and it's not whoever you're talking to in the other side of the healthcare ecosystem's fault. It's just the way that everything's been wired. Is when people hear pharmacy, they have a very biased, myopic view of what pharmacy is. It's pills and bottles. It's paid claims data. It's the really tired pharmacist that's back there and hair's all over the side and one tech running around, their phone's ringing, like line at the door. That's what people think of with pharmacy. And it's taken us a while in rural health transformation, but any other project I've ever worked on, to evolve that view in a way where people understand what pharmacy can do. And so offensively, what we did in the beginning was try to paint the picture of pharmacy a little bit different than people originally think. And so expectation of pharmacy and rural health transformation in the state of Missouri in the beginning was, well, there are these claims that come in. And remember, when claims data is reviewed, it's just the paid claims. It's not the rejected claims. It's not claims that were on cash. It's not an encounter that happened in the pharmacy. It's just paid claims for that payer, right? And so just Medicaid, they only see Medicaid claims. Humana only sees Humana claims, and so on. So, the idea that pharmacy can be inclusive of encounters. It can be inclusive of reasons people didn't pick up their medication. It could be non-medical drivers of health, social determinants of health, reasons people are not going to primary care, or that they've got other issues that are negatively impacting their health. And we had the luxury of having some amazing projects that we had worked on in Missouri and outside of Missouri, where we could collect some of this really beneficial, important data. How we framed it was, and this is on the offensive side, we framed it that Missouri Hospital Association, who is a huge participant in rural health transformation, I'm super worried about hospitals closing with the future state of our healthcare system. So Missouri Hospital Association, those hospitals, they need to be involved in this, and they need to be primary, because if our hospital infrastructure crumbles in these rural areas, we've just seen, we had a hospital close just south of me, and it's like this healthcare vacuum. I mean, it hurts the school system, hurts everybody. Yeah. So hospital associations involved. One of the reasons that the hospital association is so influential in things like this is data. So hospital association has this amazing, what they used to call the health equity dashboard. I don't know what it's called now, but it's an amazing aggregate look at what's going on in the state of Missouri from the time people get admitted till they get discharged, they go to the clinic. It's got a ton of really valuable information that helps in Jeff City. And it also helps the hospitals make decisions. It helps with value-based contracting. So what we said when we went into this was, look, y'all got everything you need there, but you have this huge gap, you being the state of Missouri, Medicaid, who oversees the rural health transformation. You got everything you need from admission to discharge, but from discharge to readmission, that's where we are. We've got a ton of information we can provide from discharge to readmission. And a lot of times that's just a data cliff where the patient walks out until they walk back into an ED somewhere. Right. And so we have a ton of examples of how we have done this in the past and how we can make this a more robust, interoperable opportunity in the state of Missouri, and that kept selling. And that got Annie and the rest of our group, Annie Eisenbeiss at MPA, from, being on the outside looking in to maybe like the little kids table to sitting at the main table at Missouri Rural Health Transformation. So offensively, we just played a game. We tried to stay in our lane, not to replace primary care, not to replace anybody in the primary care association, not to replace anything anybody's doing at the hospital association or in hospitals, but being supplemental sources of aggregate data that'll help all parties. And on the defensive side, right, we have to have one voice. When the governor's office says we want to talk to pharmacy, they can't talk to 15 different organizations. We have to have it be one organization. And we beat this dead horse over and over and over. MPA needs to be voice. And so now, thankfully, we've played our cards and we played them well. MPA is the pharmacy voice. And so if somebody wants to be involved, great, come in. But MPA is the front door for pharmacy. And then we'll work with, the chains, work with any hospital outpatient pharmacies, FQHC pharmacies, CPSN pharmacies, non-CPSN, grocers, whoever it is. And so that's our offensive and defensive play. And like I've got there's a ton of examples of where we've had to play into offense and defense based on that structure, but our structure has paid off.
That's amazing. So who is it in the state level that makes the decisions? I know you talked about Annie and the MPA, but is there an entity in Jefferson City that that's kind of head over all these things, or tell me how that's working?
Yeah, that's a great question. So each state, and I've done some work in multiple states, but I'm here talking about Missouri because I'm super excited about Missouri, and this is a Missouri podcast. So in Missouri, it's different in each state. So each state decided like who was going to be the steward of rural health transformation, the funds, and to be held accountable for those funds that come in and how they're distributed within the state. So in Missouri, the Medicaid program, DSS, was the department that was tasked to oversee and be the stewards of these funds. And so we've been working with some great folks there that are super collaborative. And, again, I think I said on this podcast last time, I'm proud to be from Missouri, and I keep being more and more proud as collaborative as this has been. So DSS is overseeing it. There's some consultants that they've hired to help support and to keep everything moving together. And then we've been working collaboratively. Our team's been working collaboratively. Our team, being the MPA team, has been working collaboratively with the other associations as a way to be engaged with DSS and Rural Health Transformation, the funds, which haven't been released yet, but all that stuff's kind of in the process. What's today? March 10th. And so right now, like we're thinking all this stuff should be released pretty quick, and then trickle down and push all that down to their members or their colleagues, as Missouri Pharmacy Association is going to do for MPA members and for other pharmacies that may or may not be MPA members.
That's pretty cool. So the timeline sounds like we are upon where things are going to start. We're going to start seeing some things happening. Is that what you're saying?
So the timelines, this first year is going to be tricky because of the fiscal year. There's going to need to be applications and bids and proposals put together for the second year starting in the fall. So in September, we're probably going to be working on that again. Funds haven't really even been released. Contracts. The way I understand it, every state sent in a $200 million proposal. Federal government came back and said, based on your application, we're going to either give you a little more or a little less. So justify the new budget. That was in January. and February, justify the new budget. In March, the federal government, CMS, was supposed to have proven, I think they've approved or asked for revisions on each of those budgets. So going into March is the first time that the funds could actually even be released. And then you've got to operationalize any of the funds to do what was earmarked within the original proposals and ultimately the contracts. So state's got a lot of work to do, a lot of framework, a lot of, we're talking about to overhauling how healthcare is done in rural counties across the entire state of Missouri, minus just a few counties which are considered urban. It's a 5-year task, and $200 million plus sounds like a lot of money, but when you're really trying to connect the dots and make sure that we keep these rural providers open, it's not much time and not much money, and we got a lot of work to do.
Absolutely.
And that's a real number, Tripp. 200 million. That's what came to Missouri. Is that right?
Yeah, and it's more than that. I think it's 216. I'm
But
sure
it's
that number
but
is right. Yeah.
but that's more than just pharmacy, right? That's
Oh,
for other
yeah.
stuff.
Pharmacy is like
Yeah.
pharmacy is just lucky to be a small bullet point in the money. Yeah, pharmacy's not getting anywhere close. That's for all the hospitals, for the clinics. That's for infrastructure building. That's for ambulance districts. That's for all. That's
Yeah.
everybody.
Yeah.
But at least now we have a structure through the MPA and the CPSN is that how pharmacists can plug into that and take advantage of that funding, right? So before it was always very nebulous. Now there's a specific script we can follow to actually take advantage of it.
Yeah, and that's a really good point. When we started, we had a budget of like I think $126 million over 5 years that we pitched to the state, and a huge percentage of that was for uncompensated care. And those were things for those encounters, interventions that pharmacists and pharmacy staff can do for people that needed help that the pharmacy and pharmacy staff couldn't bill for that encounter. Well, that was cut immediately from our proposal. That was one of the first things that was cut. So those things are disappointing because we were hoping that that was going to help prop up some of these rural pharmacies that need a little help until we can get to the point of billing for those services. But having the ability to participate still, I've been um, on both sides of negotiations and budget cuts for years, and never like to be cut. Always want to keep what you have, but I always like it when you get to the end of get to the goal line and you can punch it through, even though you may not have been the sports center pass that you wanted to get there. Sometimes you're just grinding it out. And so what MPA got approved for was interoperability. And what that means is that if you think about the healthcare ecosystem in the state of Missouri right now, they've got these health information exchanges, HIEs, that primary care groups and hospitals have fed information into that haven't been super, I won't say friendly, but not easy for pharmacies to participate. Pharmacy just couldn't, it just didn't work. And the pharmacy benefit, if you look at your insurance card, you got like your health insurance, whatever, you got that stupid little box that's pharmacy. Well, that's kind of how we're segregated on data too. It's like everybody's data is on the big card and we're in this little box over here with all this other. And so ours is just different. And so what we proposed based on the Missouri Vaccine Gap program that we had, which I think I talked about on our last podcast, and I'm sure Annie Eisenbach's been on here talking about it. Mm-hmm. We showed in the state of Missouri that we had over 100,000 encounters, touched over 90% of patients in over 90% of the zip codes in the state of Missouri, and captured a large amount of very impactful encounter data that we could participate in things like rural health transformation, value-based arrangements, and so on. So that's what got us in the door. And so that's what we're building out. And MPA is working on now is how can MPA be like Missouri Hospital Association and have an aggregate dashboard, aggregate data that we can use to advocate for pharmacy and also help pharmacy work with hospitals and work with primary care instead of us being in this little box over here with some paid claims data that's going to half a dozen payers where it's not really helping anybody locally. So that's what we got. There is, and I will say too, there is the opportunity for pharmacy to participate in other revenue, like other encounters. And that's going to be at like a local hub level. So how Missouri's set up is, I think it's going to be 7 hubs. They're mapping that out right now as we speak. And so they may even have announced that by the time this goes live. But each hub is going to have a lot of, is supposed according to the plan. So there's 7 hubs in the state of Missouri. So you got rural health transformation, 7 hubs. And in those regions, each hub is going to have a group of different stakeholders from the area, and there's going to be funds and availability to actually work locally with those funds. And I think that's a great opportunity for us in pharmacy to participate. Absolutely. Also. But like we're not there yet. We need to just take one step at a time. Right now is we got to make sure that the contracting happens with the state. MPA needs to get that stuff across the goal line, which it's looking like all that should be fine. Structure the centralized rural health transformation group at DSSS, make sure that that's all working, we're plugged in, and then start participating in the regional hubs.
This all sounds super exciting. And, I'm looking into the future. I know you're kind of already talking about the future, but do you see this as something that's going to be very positive for us over the next 5 to 10 years for the profession, for the health of every citizen of the of the state. Tell me what I mean, we don't have a lot of time, but where do you forecast this to be in 5 to 10 years? Is it going to be something different?
Well, I don't know that I'm going to predict that, but I'll say that it has the opportunity to be very impactful and even like game changer for local healthcare. Because one of the things that early on, which excited me about it, was the state was looking at, like, say I'm in Mississippi County, Missouri, right? South Missouri. We interact in Scott, Mississippi, New Madrid, a few of these our little 3 counties down here, poor, but we all know each other and work together. Same provider group, same one hospital. It's very same FQHCs. So wouldn't it be cool if we all worked together on value-based arrangements and we could track patients across provider groups and across pharmacies on behalf of that patient, and they could like carry their health information with them, and a payer, whoever that is, whether that's United Healthcare, Missouri Medicaid, whether that's Medicare, they recognize each touch point along the continuum, whether that was through the ambulance service, L&S pharmacy, or that was our local hospital or FQHC. That's the goal. Well, man, that sounds like good healthcare to me. And it sounds like it saves a ton of money and is a whole lot easier on the inpatient. So based on that, that's the goal. We'll see if we get there. I think the state's done a good job laying out a framework of what they want to do, especially compared to other states. And I'm really excited about at least giving this a test, giving this a run to see if we can make this work. And hopefully through some of these hubs, there'll be wins, there'll be losses. We'll try, we'll err, we'll fail, and we'll succeed. But hopefully after 5 years, if nothing else, pharmacy is at the table and participating, because if we don't participate, we're excluded. So we have
absolutely. Yeah, absolutely. You mentioned the special things that we're doing in Missouri, and I was actually talking to a colleague at a conference that you and I both went to just not too long ago, and the term Missouri Magic came up, and said, I'd love to be a part of that Missouri Magic. And I'm like, I kind of like that. I don't know, and
T-shirts. We need some T-shirts.
Yeah, we do. Yeah. We need to have the Missouri Magic Pharmacy Frontiers T-shirts. There we go. And pass those out to all the listeners and people that are helping support the cause. So, Daniel, you want to ask a few final questions here?
Well, Tripp, tell us, I don't own a pharmacy. How can a typical pharmacist out there that's listening to this podcast, how can they get engaged with this? How can they make this happen?
Yeah, it's a great question. And so you teed up something that I wanted to talk about. So if you're a pharmacist in Missouri, MPA member or not, CPSM member or not, work at a chain, working independent, it really doesn't matter. Rural health transformation, which is the topic here, is really for rural health. And it's rural healthcare. It's not for certain chains, it's not even for a hospital versus clinic versus rural health clinic versus whatever. It's for all of us to figure out a way to have better interoperable patient-centric healthcare. And so if you want to participate and you're a pharmacist in the state of Missouri, you want to learn more, contact the Missouri Pharmacy Association. It's as simple as that. Just contact the association. You don't even have to be a member. We'd love for you to join, but if you're not a member, that's okay. That's the front door of this. And there's all the information you could ever want to know about what Missouri Pharmacy Association has done, where we are in participation, and what's going to be needed. So I mentioned these regional hubs. So there's going to be regional hubs. We're going to have participation in each of these regional hubs. If pharmacy is not at the table and participating, pharmacy is going to be included in each regional hub. Plus, it's not going to be a good look for pharmacy if we've got a strong voice in Jefferson City, but we've got 2 regional hubs with no representation. So we need you. Like, we need all pharmacists in the state of Missouri to be aware of this and want to participate. And then additionally, those hubs, those are going to be broken out into some smaller little regions, whether it's like 2 county, 3 county regions. And so there's going to be, unless you're in and so there are a few urban counties that are not in this rural health transformation initiative. But I firmly believe that whatever we develop in rural health transformation is going to end up embedded in these urban counties. So even if you're in an urban county, don't worry about that. Please engage Missouri Pharmacy Association, because your input could be valuable for us, because it's coming your way too, assuming that we can get this thing going.
Right. That's pretty exciting stuff when you start talking about all that. And, I've already been asked to serve on a few committees with different organizations in the area in Southwest Missouri. I've actually just got asked to speak at a little conference in Joplin here next month, and I'm like, I'm going to have to buff up on rural health transformation for pharmacy side of things. So I may be picking your brain a little bit, Tripp, to make sure. I think I have an idea, but I don't know. There's so much stuff to talk about here. It's very exciting. Sometimes it's hard to see where we're going to go, but I think we're making some progress. I appreciate all your efforts. It's been an exciting ride getting to where we're at, and I think it's going to be more exciting traveling along for sure. So,
well, the MPA team, and this isn't this Tripp going on and on about MPA. The MPA team has a very sound handle on rural health transformation with talking points, with perspective. So nobody should feel intimidated to talk about this, because MPA is developing resources and has the ability to at least connect you to somebody either in your region or in the state that's read into this, and then tell you exactly how you can help. So it's already happening. Tim, I think your example is a great example. I hope that we hear that same thing from many others, that they are asked to participate, and then they should feel comfortable. They can contact MPA and feel comfortable going out to their meeting.
Tripp, let me just put an exclamation point on that, because I think so many people think, well, we're just the Midwest, we're just Missouri, we're just a flyover state, we're the last ones to get the PDMP in the entire country. But the reality is we have great leadership at MPA. We have great leadership in the state with you and Christian and Tim and others that are leading the way, and that this rural transformation project is just another example where Missouri really is a leader, and we need to step up and take ownership of that, take responsibility for it, and make it even better. I think that's a great point.
Totally agree.
So, yeah. So we're going to wind down here, Tripp. And I know we've had you on before, but I'm going to throw this at you again. We usually try to throw something out at our guests to kind of share a little bit of something, and then maybe you got something new, who knows, or maybe it's the same thing about yourself that not everybody may know about Tripp.
Yeah. And so thinking about this right before Tim told me that we were going to do this again, I was like, I know I was on this podcast before and I can't remember what I said. So a couple of things that surprise folks sometimes about me. One is I never wanted to be a pharmacist. I'd never planned on coming home and practicing pharmacy and community practice. Never did. And I graduated in the bottom third of my pharmacy school class while I was there. So a lot of people were surprised for many reasons that I ended up, being a 20 whatever year community pharmacist in small rural Charleston, Missouri, because that was never my plan, and it took me a lot to even get to that point.
And here you are leading our state, leading our nation's profession in these efforts. And I know you're not the only person on the team, but there's a lot of people that look up to you, and I'm one of them. And I appreciate all that you're doing for our state, for our profession, and for the nation, for that matter. So, Daniel, do you want to finish it out?
Tripp, can we get you committed, Tripp, to come back in a year or so with maybe Annie next time? We kind of, instead of being a transformation, it can be a report of this is what we did and it's been transformed. We put that in the past tense. That'd be great to get you back on to just do a review of what happened.
I think that's a great idea. Great idea.
All right. Well, thank you for joining us. Thank you for being another guest on the Pharmacy Frontiers podcast.
Appreciate y'all. Enjoyed it.
All right. Well, have a good one.
Thank you for joining us today for the Pharmacy Frontiers podcast. And please share this episode with your friends and colleagues, and seek out the previous Pharmacy Frontiers podcast on your favorite podcast channel.